Hello, my name is Catherine Thomson, and this is an audit of pain management in patients undergoing cytoreductive surgery with or without HIPEC. This project was completed at the Mater Hospital, where I was a senior house officer in anaesthesia, alongside Doctors Dulmi, Nawarathna, and John MacHale. Cytoreductive surgery, with or without hyperthermic intraperitoneal chemotherapy, is associated with significant postoperative pain. ERAS guidelines recommend thoracic epidural analgesia as first-line therapy, alongside multimodal opioid-sparing strategies. This audit aimed to evaluate epidural utilization, block adequacy, and postoperative analgesic outcomes in CRS HIPEC patients, while identifying opportunities for service improvement and providing evidence to guide the development of a local perioperative CRS HIPEC protocol. The population included all patients who were planned to undergo CRS HIPEC at a tertiary center in 2024. Data were collected from anesthetic and critical care records. Collected variables included epidural use, insertion level, composition, reasons for epidural omission or failure, alternative analgesic techniques, pain scores, and opioid consumption in the first 48 hours postoperatively. Adequate epidural analgesia was defined as bilateral sensory block above T6. Of the 59 included patients, 88.1% had an epidural sited, though epidural insertion was attempted in 93.2%. Of the 7 patients who did not have an epidural placed, 6 received rectus-sheath catheters, and 3 received intrathecal morphine as alternatives. Only 42.5% achieved an adequate block. Inadequacies were due to low block height, unilateral blocks, or dose reduction for motor block or hypotension. Opioid consumption in the first 24 hours was lowest in patients with adequate blocks, with a mean morphine equivalence of 19 milligrams, and highest consumption was in motor block cases, with an average of 94 milligrams in the first 24 hours. Alternatives such as rectus-sheath catheters or intrathecal morphine demonstrated relatively low opioid use with an average of 26 milligrams in 24 hours. Patients with adequate epidural blocks reported mild or no pain in the first 48 hours postoperatively, whereas those with inadequate blocks had higher rates of moderate pain. Alternative techniques such as rectus-sheath catheters or intrathecal morphine were associated with similarly low pain scores to adequate epidurals. Despite high rates of epidural use, over half of patients had suboptimal blocks, which was related to higher opioid use. To improve these outcomes, there are several strategies we can focus on. First, we recommend optimizing insertion level where possible, which would be ideally T5 to T11 as per ERAS. For cases where epidurals are contraindicated or fail, we recommend using combined spinal epidurals alongside rectus-sheath catheters as rescue therapy. Always ensure to maximize the use of non-opioid analgesia options such as clonidine and NSAIDs both intraoperatively and postoperatively. And then improved multidisciplinary communication is imperative. We plan to emphasize staff education about postoperative epidural management due to the high opioid burden that was associated with reduced infusion rates. Overall, this audit has aided in the development of a local protocol for managing these patients. By implementing these changes, we hope to reduce opioid exposure, enhance patient comfort, better align our practice with ERAS guidelines, and ultimately set a benchmark for perioperative pain management in patients undergoing cytoreductive surgery with or without HIPEC.